Hello, I'm David Kerr, Professor of Cancer Medicine from the University of Oxford. Today I'd like to talk a little about a case that we had some time ago and to talk about patients with colorectal cancer who are also pregnant and how do we manage that. It's a rare event, only 1 in 13,000 pregnancies are associated with co-occurrence of colorectal cancer, and therefore the literature on it is scattered, tends to be anecdotal. Our patient presented at around 27 weeks of gestation. Up until then she had been well, but had a recurring problem, increasingly so, of right upper quadrant pain, which was referred to her right shoulder. The obstetric team did an ultrasound and noticed that she had metastatic tumour deposits in her liver, and eventually we discovered that she had a sigmoid cancer, hepatic metastasis. The biology of the cancer was BRAF wild type, KRAS mutant, and was mismatch repair proficient. Therefore, somebody that would be a candidate for conventional chemotherapy. Giving chemotherapy, the drugs that we tend to use, 5-fluorouracil, oxaliplatin, irinotecan, in the third trimester is relatively safe. The likelihood of there being any prolonged delayed damage to the baby is low. That there may be a reduction in growth, intrauterine growth retardation, so the baby on delivery may be a little small, but otherwise one wouldn't expect any long-term sequelae. Of course, the physiological changes of pregnancy, with increased blood flow, the metabolic challenge of hosting the baby, do present some pharmacokinetic problems. But there are some interesting is the wrong word, there are some desperately important, compelling, moral and ethical elements to this as well. One would prioritise the mother on discussion with the family, and therefore, is there any way that arriving at the stage of pregnancy could reduce the chances of the mother responding to chemotherapy? There are no data to suggest that, but clearly one must navigate, as I said earlier, the physiological changes associated with pregnancy and do our best to deliver optimal chemotherapy. We've done so with FOLFOXIRI, so we've thrown the chemotherapeutic kitchen sink with the hope that by giving around 4 cycles of chemotherapy at intervals of 2 weeks, that would get us to around 35-36 weeks of gestation, a break of 3 weeks before delivery so that we're away from any thrombocytopenic or neutropenic complications of what would be very likely to be delivery by caesarean section. Clearly all of this depends on the chemosensitivity of the tumour. And again, we just don't have enough information to understand are these tumours more aggressive, do they respond more or less well. But clearly with a very significant hepatic metastatic tumour burden, 70-80% of the liver replaced by cancer, there is the added metabolic effect of parenchymal hepatic damage that may complicate our delivery of, say, irinotecan if the bilirubin starts to climb with alkaline phosphatase, and there's nothing that we can do to stent. An extraordinarily difficult situation, and we're very lucky in Oxford that we managed to engage with a wider multidisciplinary team with fetal medicine, with very high level maternal physicians care, obstetric care, obstetric anaesthetics, palliative care, so wrapping a wider but coming together quickly and effectively to deal with what was a rare problem. We'd expect that the response rate would still be around 65% to this combination of drugs. We know that the likely duration of response is for many, many months, and with modern medicine, patients with hepatic metastatic colorectal cancer have an expected life expectancy of around 24, 30, beyond that months, and therefore the idea of travelling positively, not being able to promise cure, but being able to, on average, hope that the mother would have those first 2 to 3 years of life with the newborn child is a challenge that all of us faced. So the Folfox theory can be delivered safely, and again some anecdotal evidence of that. But I think for those of us involved in the care of that young patient, we drew strength from the broad multidisciplinarity of our team. And perhaps that's the point that I'd like to make. We're used to working within our own cancer MDTs with our specialist surgeons and radiologists and so on. But in this setting, I think we were enormously lucky that we could draw on a wider community, a quite wider community of colleagues to provide absolutely optimal care and to make a decision that that care would be best delivered from the maternity hospital rather than from the cancer hospital. An interesting case, an important one, and one that had many of us having anxious and sleepless nights, even at this late stage in one's career, how one can so worry about individual patients. So I'd be very interested if any of you have had the experience of looking after pregnant cancer patients and how you manage to provide optimal care for them. As always, thanks for listening, and for the time being, Medscapers, over and out. Thank you.